everyone, and thank you very much for the kind introduction. I'd like to start by thanking Diagnostic Green for supporting this major effort to put together a webinar series with what I believe is going to be, in the next decade, the most revolutionary technology that will enable surgeons to do safe surgery. The topic of today is fluorescent incisionless cholangiography during laparoscopic cholecystectomy. And the question I'd like to pose is if this is a new gold standard. These are my disclosures, and those are companies that I work with. And besides Diagnostic Green, none of them are related to my presentation today. If you look at Pusher's publication in surgical endoscopy in March this year, the Task Force Safe Cholecystectomy from SAGES published the outcome trends and safety measures after 30 years of laparoscopic cholecystectomy, then perform a systematic review and the pooled data analysis. And I would like to call your attention about the N number. They looked at 500,000 plus cholecystectomies, 151 studies, and they were really looking at bile duct injuries. 18 of those were randomized trials that accounted for 4,500 patients. 117 were single center cohort studies that accounted for 115,000 plus patients. And there were additional 35 multicenter cohort studies that accounted for over 380,000 patients. And as you can see here, the bile duct injury pooled range was between 0.32 and 0.52%, much higher than reported in the literature. Morbidity of 1.6 to 5.3%, mortality of 0.08 to 0.14%. The IOC rate was 5.6 to 26%, with a conversion rate that ranged from 4.2 to 6.2%. Further, SAGES did an expert Delphi consensus looking at critical factors for safe surgical practice during laparoscopic cholecystectomy, and 407 SAGES committee members had to list items for safer practice, and then they achieved a consensus on 15 items. Some of those are to establish the critical view of safety, understanding of the anatomy, the adequate exposure, the ability of the surgeon to call a senior colleague for help, and last but not least, the fifth top item was to recognize when to convert or abandon the procedure. So if we look at all the different steps we just mentioned, expertise, critical view, cholangiogram, possible doing an ultrasound, there's something missing in our opinion, and that is fluorescent imaging. Fluorescent imaging increases the visualization rate, it guides the surgeon, helps in misidentifying structures, decreases OR time, bleeding, leaks, and does it decrease bile duct injuries? All these are potentials for this new imaging technology that I would like to discuss with you today. If we look at the history of fluorescent imaging of the biliary tree, it is nothing new. And one has to wonder what took us over 50 years to get onto this technology. Probably the reason why was not only human mentality in being very slow to adopt new technology, but also that the technology wasn't there. In 1953, there were already studies published on the extrahepatic biliary obstruction in mice, and they were doing fluorescent microscopy. 3 years later, they did fluorescent imaging of the biliary system following parenteral hematotrophin administration. And in the 1970s, there was a fluorescent microscopic study on bile duct proliferation in guinea pigs, all these animal models. Fluorescent cholangiography in a mouse model was an innovative method that might improve laparoscopic identification of biliary anatomy. Was first published in surgical endoscopy by Stiles in the British Medical Surgical Endoscopy as well. And you can see here with stereo microscopy in a mice model how you can, using fluorescent imaging, to identify biliary structures, the normal anatomy, a bile leak, or biliary obstruction due to stone disease. But in reality, the first one who did a human experience and publication in the world literature using intraoperative fluorescent cholangiography, using indocyanine green as a biliary roadmap for safe surgery, was Takeaki Ishizawa, who is currently the president of the International Federation of Fluorescent Guided Surgery. And that publication came in 2009 at the Journal of the American College of Surgeons. What he showed was literally, as you can see here, that the fluorescent imaging of the biliary tree was as accurate as intraoperative cholangiography. And you could achieve nearly a similar success rate or higher by injecting this fluorescent imaging preoperatively. So after the preoperative injection of ICG, he demonstrated the cystic duct before the dissection of Carlos triangle in a patient undergoing a cholecystectomy, with the exception of one patient. The powerful message of this publication of fluorescent imaging is that this imaging technology happens before the surgeon has to act, before the surgeon will dissect or will cut. And that's why we call it fluorescent incisionless cholangiography. Multiple publications have been posted in the literature ever since Ishizawa's first one in 2009. And I'm going to briefly go over some considerations like technical aspects, the impact this might have in our daily practice, and what we consider could become a standard of care. This is a study to optimize near-infrared fluorescent imaging cholangiography for open or laparoscopic surgery. And without getting too much into the nitty-gritty of these difficult and colorful tables, what it's showing you in 27 patients, 20 of those undergoing liver resections and 7 undergoing a pancreatic or ampullary resection for carcinoma, there was no major difference in the imaging of the liver of the biliary tree. And you can see when the ICG was injected into these patients, 5 milligrams 30 minutes before surgery, or even 20 milligrams 24 hours before the surgery, which is what is recommended for liver surgery and biliary tract tumors. So this study showed that a dose of 10 milligrams of ICG injected prior to surgery, 24 hours prior, will provide a significant lower imaging of the liver. Further, Vieck in surgical endoscopy published last year that biliary tract visualization using near-infrared imaging with indocyanine green during laparoscopic cholecystectomy could improve also our outcomes. And he did a systematic review of 19 papers, 9 studies using a 2.5 milligram fixed dose, 6 studies at 0.05, which is probably irrelevant for the audience. But in reality, what they showed is how nicely we can see the biliary tree. Here you can see the imaging, how you can remove the adhesions before the dissection. Here you can see the gallbladder, common bile, the cystic duct, and the common bile duct. And this is the liver bed. Then we get to the critical view, which is so important, how the surgeon can not only look at something, but also touch with white light or with near-infrared light. And I think this has to be said loud and clear. We're giving surgeons back the tactile perception because now they can see and touch something while dissecting. This is unique to fluorescent imaging. Another nice maneuver that Fernando Dipp described is the reflux maneuver that will allow you to see nicely, as you can see here, the cystic duct emptying into the gallbladder. And last but not least, the other major advantage of this technology is when you're dissecting the liver bed and you finish with your cholecystectomy, you can check the liver bed for small bile leaks. You can check the liver bed for Luschka ducts, which are accessory ducts that you can otherwise not see using conventional cholangiography. Again, the major difference between conventional cholangiography and this technology is that this is a dynamic view. that is accompanied with the movement of the surgeon, with tactile perception. At the same time, you can visualize what you're cutting. Conventional cholangiography will give you, despite all the efforts to use, fluorescence, will give you a static view that you cannot repeat while you are dissecting. You can see how nice a surgeon is detaching that gallbladder from the liver bed, and how the liver bed can be visualized at the same time without any spillage of bile containing indocyanine green. Here you see the dissection with white light and the dissection with near-infrared light. Both of them together are a very powerful tool to not only speed up the procedure, but more important than that, to make it safer. Together with Dr. Deep, we did a very nice study using fluorescent imaging as a teaching tool to identify callus triangle. So we took pictures at the same stage during dissection in 10 different cases of laparoscopic cholecystectomy. We took 20 pictures, we organized them at random, and then we had 20 students and 20 residents look at those pictures, and we asked them to identify the biliary anatomy. And the results are telling, and the reason why the results are so important to us in this study is because none of them are experts. And you can see here, if you look at the xenon or white light in black and the near-infrared fluorescent imaging in green, how the students could identify the cystic duct, the main hepatic duct, or the junction between the cystic duct and hepatic duct. So really, a novice to surgery that is not familiar with biliary tract anatomy, when asked, where is the cystic duct, where is the main hepatic duct, and where's the junction, was able to recognize that in over 80% of the cases, while only in 33% of the cases when using white light. And what happened with residents? It got even better, because you see that over 90% of the cases, 95, 96, and 99%, the resident was always able to identify where the cystic duct was here in the left upper quadrant, where the common hepatic duct was, and where the junction was when using near infrared light. So what we showed here also, that it reduces the time for the residents or the students to identify all these structures while they're having training, while they're during training and they're going through their learning curve. So I think this is a very powerful tool, because as I will mention to you at the end of this presentation, the experience of the surgeon makes a major impact when recognizing biliary tract structures. The accuracy of near-infrared surgery in morbidly obese patients undergoing laparoscopic cholecystectomy, another nice publication from Dr. Deep in obesity surgery, looking at the BMI of the patients. Does BMI matter? Does the fatty liver, and the fat around the hepatoduodenal ligament make a difference? And as you can see here, there was no major difference between BMIs when conducting near-infrared cholangiography. Overall, in 70% of the cases, you can see the hepatic duct. In 87% of the cases, the common bile duct. And in 7% of the cases, you can even see an accessory duct. And this is also a very important publication from Dr. Deep that I believe is telling, and that is cost. We live in an era where healthcare costs are going through the roof due to many reasons, and this cost analysis and effectiveness comparing the routine use of fluorescent cholangiography with fluoroscopic cholangiogram in patients that are going laparoscopic cholecystectomy shows that if you conduct an IOC, the cost of that diagnostic method is close to $800. Well, if you conduct a fluorescent cholangiogram, the cost is $32. The interesting thing is, as I mentioned at the beginning, the IOC needs an incision, the IOC needs a technician, needs very expensive equipment. It's a static, one-time imaging, or even dynamic if you do fluoroscopy, but it's not coupled to the movement of the surgeon it's not active, it's not dynamic. It doesn't allow the surgeon to touch while they're looking at a structure. So I believe this is a very, very powerful and telling study from Dr. Dib. So the big question that I'd like to pose to finish is if fluorescent cholangiography will become standard of care or not. So in an effort to find if this is going to happen or not, together with Dr. Dib, we conducted a multi-center trial that we just concluded between Cleveland Clinic, main campus, Cedars-Sinai Medical Center in Los Angeles with Eddie Phillips, Fernando Dib in Buenos Aires, Takeaki Shizawa and Professor Kokudo at the Medical University Hospital in Tokyo, Thomas Karas in Hamburg, Luigi Boni in Varese, Italy, and finally Silke Schneider in Rostock, Germany, all expert surgeons in biliary tract. And we did a 2 arms multi-center randomized controlled trial with patients that were randomized by each center. And the randomization, in one arm, surgeons will use white light and near-infrared light. And in the other arm, they will use white light alone. And because we're publishing this in a major peer-reviewed journal, I'm not able to show you all the findings. But I can tell you as a big take-home message that surgeons' experience makes a significant difference in recognizing biliary radicals. As I mentioned to you before, using near-infrared light will help you identify the structures, but experience of surgeons will matter in identifying biliary tract radicals without the use of near-infrared lighting. And one of the things we observed in the group with near-infrared light in this multi-center trial was that if you use near-infrared light and white light, you had no common bile duct injuries, 0%. While in the group that used white light alone, the incidence of common bile duct injuries was twice as high. So it was much higher than in the group with near-infrared light. So what do we expect from this method in the future? It will help you identify and confirm extrahepatic biliary tree. It will guide you during dissection, will improve your visualization when compared to white light. It will help residents in the OR to learn faster and educators to be safer teachers. And it will complement other methods by giving you more information. A big question that I get posed all the time, and what happened with the common bile duct stone? Well, this technology is not meant to replace cholangiography for biliary tract. This technology is meant to complement white light for safe operation and to minimize, if possible, to get to disappear injuries to the biliary tree. I would like to invite everyone to attend the DDI week that is going to take place in February between the 13th and 19th in 2019, and attend our 18th annual Surgery of the Foregut Symposium, as well as the 6th World Congress of Fluorescent Guided Surgery that is going to be under the presidency of Takeaki Shizawa. And last but not least, I'd like to thank Fernando Dib, that you see here, who has been the motor here at the Cleveland Clinic to develop this new technology, and with whom I've been working for the last 5 years, trying to develop further new visualization techniques in the GI tract using fluorescent imaging. And I'd like to stop here and thank the audience, and I'm open for any questions.
Thank you very much, Dr. Rosenthal. And as we mentioned, we are now going to start answering the questions that have been submitted so far during the presentation. As a reminder, you can still send your questions in through the questions pane in your attendee control panel. So, Dr. Rosenthal, our first question here is, what are the benefits of ICG I can't pronounce that word, cholangiography over the conventional cholangiogram?
Very nice, Gil. You made it. You made it. Well, as I mentioned along my presentation, there are multiple benefits. Number one, that it is incisionless, that you don't need to cut in order to do a cholangiogram. When you do a cholangiogram, you dissect what you think is the cystic duct, you cut what you think is the cystic duct, and you do your cholangiogram. So if you have misidentified with white light what you think it's a cystic duct, but you're working on the common bile duct, by definition, you have already a common bile duct injury. And that is why we say, and this is Ed Phillips' legacy, that cholangiography doesn't completely remove the risk of a bile duct injury. It does decrease the level of injury, because if you do a cholangiogram routinely, even if you misidentify a structure, and even if you injure the biliary tree, it's a level 1 injury. You do a cholangiogram, you don't see the upper radicals, you repeat the cholangiogram with the patient head down, and if you still don't see the upper radicals, most likely you're on the common bile duct and not in the cystic duct. But with fluorescent imaging, you don't need to do that. You don't need to cut any structure. You just need to visualize. You can dissect the fat from the hepatoduodenal ligament using a blunt grasper without the use any kind of energy source, and you'll be able to identify the junction between the gallbladder and the cystic duct, between the cystic duct and the common bile duct. You can see the common bile duct. So this is, I think, the number one and most important advantage. Second, as I mentioned before, you don't need expensive equipment from radiology. You don't need to wait for the radiologist. You don't need to have the skills to do the cholangiogram because it requires no skills, but visualization with near-infrared light. You don't depend on a technician. And the cost is dramatically lower when we talk about $800 versus $32. It is, I would say, from a time perspective, easy to be done, can be repeated endlessly during the procedure, and it is safer and cost effective. Any other question?
Yes, we've got another couple of questions in for you. You mentioned there about it being a cost-effective procedure, but what about the equipment itself? Is the equipment costly that you need?
No, it is not. You can modify your scopes, the cable that you use when conducting your cholecystectomy. So a couple of light cables, they have to do some small changes in your light source. All this if you have old equipment. But compared to a C-arm that you use to do a fluoroscopic cholangiogram, it is, I would say, minimal compared to the OR time that you need for a fluorescent cholangiogram. It's minimal. And I would say that for those who are starting their careers in biliary tract surgery, most equipments in 2018 moving forward are going to have near-infrared lights. And that is not only conventional laparoscopy, open surgery, and also robotic surgery. They all are coming with fluorescent near-infrared imaging capabilities.
Thank you very much. And another question here is, how difficult would it be to implement this type of technology into a surgeon's practice?
It is very simple because you don't need to be, I would say, registered. You don't need to be approved by your medical executive committee. This technology, this imaging modality, the ICG, has been approved by FDA since 1956. So the drug has minimal, negligible, and extremely rare side effects. The dose is extremely low to trigger those side effects. So it is very simple. I would say it's much safer than doing a routine cholangiogram. We let the patients know that we are using near-infrared imaging to visualize their biliary tree to make the surgery safer. That's all. So it's really extremely easy to implement this into your practice.
Thank you very much. And moving to the final question that we have in at the moment, do you believe that this technology will become the standard of care? And if so, in what sort of timeline do you think that will happen?
Well, I do believe that this technology will become standard of care. At least in my practice, it's become already standard of care. And I'm certain that many surgeons, as they become familiar with the ease of conducting a fluorescent imaging cholangiogram will adopt this as their routine and standard technique to image the biliary tree when doing a cholecystectomy. I believe that our multicenter trial, in conjunction to all the literature that has been already published worldwide, is going to further help to solidify that this technology is not only feasible, but it is safe and it decreases biliary tract injuries to zero, which is our goal. The injury of the biliary tract results not only in major debilitating complications for our patients, including mortality, but it's extremely costly. Some of these patients need to go all the way to a liver transplant. There is mortality associated with all this. And last but not least, bile duct injury has major litigation costs. So why not adopt an imaging modality at a minimal cost that is very easy to implement in your practice, that doesn't represent for you to do extra learning or courses, and will allow you to conduct your surgery not only faster, because laparoscopic cholecystectomies in 2018 are done probably in 20 to 30 minutes, but it will allow you, more important than that, to do a safer operation. So I am convinced that this is the way to go. Probably, since there are not that many questions being posed, I'd like to make a comment regarding the intraoperative injection of fluorescent imaging dye of ICG into the gallbladder. This is another possibility. If you are a surgeon conducting a cholecystectomy and you are unable to visualize the biliary tree, and you did not inject the patient preoperatively, so what you can do is take the ICG and inject it into the gallbladder directly, trying to minimize spillage, of course, in order to prevent that from changing the view of the biliary tree. But that has been used by many centers also as an aid during a difficult cholecystectomy. So the intraoperative injection of this dye into the biliary tree has been also extremely helpful.
Thank you very much, Dr. Rosenthal. I wonder if you could just go back to your previous slide, because we've had a question regarding the events that you were mentioning, and asking how people would get more information on those events and how they would sign up.
Well, if you look at the bottom here, you go to the www.ccfcme.org/DDSI week, and you will come to the 18th Surgery of the Foregut Symposium that will take place in Fort Lauderdale next year. And with that, you will be able to easily register. It's going to be a 5-day symposium, 4 days of lectures, 1 day of live surgery, with all kind of fluorescent imaging technologies, something that the audience will be able to enjoy in coming webinars. Fluorescent imaging of the biliary tree is just one of the many, I would say, applications of this exciting technology. It's been used also for other areas of the GI tract to see if there is good blood perfusion. We use it for esophagectomies. Colorectal surgeons use it for colectomies. It's been used also to identify the ureters. It's been used in the field of oncology, as we will hear in future presentations, to identify sensitive lymph nodes. And I believe that we'll see more and more implementation of fluorescent imaging in oncology to identify tumor cells and verify, the efficacy of our treatment modalities.
Thank you very much. And I have just dropped that link to www.ccfcme.org into the chat box to the audience, so you can now click on that link and get some more information. So, Dr. Rosenthal, it just leaves it to me to hand back to you for any closing remarks before we end today's webinar.
Well, I'd like one more time to thank Diagnostic Green for supporting these efforts, and obviously Dr. Dip for the hard work in putting together this webinar. And I look forward to the upcoming webinars with exciting speakers, putting us, up to date with this new and exciting technology as fluorescent imaging. Thank you very much.
Thank you very much, and thank you everyone for attending today's webinar. We would like to take this opportunity to notify you of our next webinar, which is for New Frontiers in Fluorescent Endocrine Guided Surgery, which will be held on Friday, July the 27th, and at the same time, which was 7 AM EST, and we would love you to join us for that. Once you leave today's webinar, you will receive a survey on the presentation. It's just a few really quick questions, so we would be grateful if you could keep your browser window open and complete that and provide your feedback for us. You will then receive a follow-up email within 24 to 48 hours, which will include a link to a recording of today's webinar. On behalf of the International Society of Fluorescent Guided Surgery and our presenter, thank you so much for joining us, and please do enjoy the rest of your day. Goodbye.